Awesome, thank you. So hi, everyone. I think we'll get started. We may have a few folks joining us a bit late, but thank you for coming. As you may have heard, we are recording this seminar. This recording will be made available via our website, our YouTube page of the Gilbert Center after the seminar. So if you don't wish to be in the recording, please just turn your cameras off and that will be taken care of. So welcome. Thanks for coming to what is our final seminar of this year, the 2021-22 Gilbert Annual Seminar Series. And we're really pleased to be co-sponsoring this seminar with the Department of Health, Aging and Society. This is a series that we do each year that we really seeks to create opportunities for the exchange of ideas and sort of stimulate discussion amongst researchers, graduate and undergrad students, community members, and older adults. And this year, our seminars have explored the theme of critical explorations of care in an aging society. And we're really thrilled to have Dr. Rachel Heron with us today to present a seminar on safe places for aging and care, exploring violence in care for older adults. As per, proper Zoom etiquette, we asked you to keep yourselves on mute during her presentation to avoid background noise. Dr. Heron will present for about 40-45 minutes, and we'll leave that last 15 minutes for questions and answers. During the presentation, please feel free to type your questions into the chat box at any time. We can read it on your behalf at the end. Or you can unmute yourself during that question and answer period to ask Dr. Heron your question directly. So without further ado, I will introduce Dr. Rachel Heron. She's an associate professor of the Department of Geography and Environment at Brandon University, Tier 2 Canada Research Chair in Rural and Remote Mental Health, founding director of the Center for Critical Studies of Rural Mental Health. Dr. Heron works with researchers, students, and community partners to respond to issues related to rural mental health, aging, and care. And her research examines safety in settings of care, which I think we're going to hear a bit more about today, the diversity of experiences living with mental health conditions, and sort of social inclusion as well. So please join me in virtually and very warmly welcoming Dr. Rachel Heron.
All right. Thank you, everyone. Thank you for the introduction and for the opportunity to share our research today. So before I get started, I just want to acknowledge that the main campus of Brandon University, where I'm currently located, is in Treaty 2 territory, and it's the diverse gathering place of Indigenous people, including the Dakota, Anishinaabe, Oji-Cree, Cree, Dene, and Métis people. So the research that I'm presenting today is possible because of the treaties and in acknowledging the treaties and the many Indigenous peoples that share this territory with Brandon University. I want to express my respect for the teachings of these lands and their influence on the people and care within this place. I also want to acknowledge that the project that I'm presenting today is called the Safe Places for Aging and Care Project. I am the principal investigator of this project, but the work that I'm presenting is certainly not my work. It's the work of a team. And in particular, I want to acknowledge the work of postdoctoral fellow Dr. Sheila Novick in leading the document analysis component that I'll be sharing with you today. Yazzie and Kevin, who are research assistants, who did a lot of the analysis, and the work of Shelby and Kira, who have been actively working on transcription of the interviews that I'm presenting. So all of this is possible because I have a wonderful project coordinator, Madeline Kruth, and also a really wonderful team of co-investigators who contribute conceptually and methodologically, because this has been a difficult project to do, especially in the last 2 years. So I just want to acknowledge all of those wonderful people that have made this work possible. So over the past few years, I would argue that there's been significant international and national attention directed to the failures of our long-term care systems, not just in Canada, but across the globe. And these are failures both on the part of older adults and those who work in long-term care. The media and many aging researchers have drawn attention to issues of understaffing in residential care, poor wages for care workers, neglect of residents, and all of these things have had devastating effects on the lives and deaths of millions of aging persons globally. But a lot less attention has been directed to the long-standing issue of violence as a continuing health and safety issue. My interest in violence in conditions of care started during my field work for my doctoral dissertation, which now seems like a while ago. So in 2013 and 2014, I was interviewing people who identified themselves as former partners in care to a person living with dementia. So they'd cared for someone living with dementia who had passed away within the past 1 to 5 years. And I thought that by interviewing these people, I would get a better sense of sort of transitions in care, what it is that people needed throughout the condition. I was also interviewing people living with dementia, but this sort of subgroup of former caregivers would help me to really understand kind of the big picture, I thought. And I didn't expect to hear anything about violence during this time. You know, I was focused on care. In a lot of ways, I see care and violence as being kind of oppositional things, things we don't put together, right? But what I found in talking with these caregivers was that, well, 9 of the 27 that I interviewed were talking about aggression or violence. Those were the words that they used when they were caring for a person living with dementia. I found that they really wanted to talk about these actions that they described as violent or aggressive, but that the stigma associated with them made naming and introducing these actions difficult, that partners in care also sought to protect and defend the person with dementia for whom they cared. Sometimes they were afraid to talk about these things, particularly when they were talking to healthcare workers. They didn't want that person to be quote unquote put in a home. So they would gather together information that they knew about the person, about the environment, about people around them, and the circumstances to try to prevent and respond to these actions. And so this is the work that's really kind of fueled my continuing interest in how the conditions and relations of care, whether they be at home or in residential care settings, can shape violence and safety. So over the past 2 years, when we're looking at the growing literature on violence in long-term care settings, what we find is that violence is a pervasive problem within long-term care in Canada and around the world, and that it's also a multi-directional problem. And what I mean by multi-directional is that it affects residents, family members, and paid care workers, and it can go both ways. And we can see that in the range of terms that are used to describe violence within long-term care settings. So one Canadian study by Albert Banerjee and colleagues found that 90% of residential care workers in 3 provinces experienced physical violence from residents or their relatives, and 43% encountered some form of violence on a daily basis. Another Canadian survey of long-term residential care workers in 3 Western provinces found that workers experienced, on average, 3 responsive behaviors from residents over their past 5 shifts. And I should note here that the term responsive behaviors is used to describe and promote understandings of aggressive actions or words of people living with dementia, with the aim to draw attention to the conditions that shape these actions. So this is recognizing this is an expression of need, and we need to pay attention to what's going on around that individual. Residents of long-term care facilities also, of course, experience high rates of violence. So it's not just the workers that experience violence. An international systemic review of elder abuse within institutional settings estimated that 62% of staff reported engaging in abusive actions. So that included psychological, physical, sexual, and abuse and neglect toward residents over the past year. Emerging evidence also suggests a high prevalence of resident-to-resident violence within long-term care facilities. So a study in the US, for example, found that 20% of residents experienced physical, verbal, and sexual mistreatment from another resident over a 1-month period. So the point that I'm trying to get across is that violence is relatively common. It takes place in a lot of different directions, and it's shaped by relations and conditions of work. All of these, I'd like to say that all of these forms of violence are related in the sense that they take place within the same sort of conditions, and yet academic research on violence tends to look at each of these different types of violence separately. And so our approach is different in the sense that we, in the Safe Places Project, we're trying to provide a systems level perspective on responses to violence by examining policies, practices, and experiences of diverse actors across home care and long-term residential care settings. So our goal is actually to explain how and why particular features of local care environments and broader organizational and policy decisions influence or inhibit violent actions among older adults and carers. And then ultimately, in an applied sense, we want to be able to inform more effective strategies, because we know that at this time, given the prevalence of violence, the strategies that are in place aren't working effectively. So to do this, we started in late 2020 to rework our CIHR proposal in the context of COVID. I actually submitted this grant before COVID, and so it involved a very inductive, on the ground sort of study design where we were going to be in place in long-term care facilities. Over the last 2 years, that really hasn't been possible. But I must say that I am amazed with the efforts of our knowledge user team. So we haven't been in place in long-term care facilities or, going into people's homes, but we are working with the nursing unions in Manitoba and Nova Scotia, with the Alzheimer's societies, with long-term care organizations, and other people who are working in the healthcare sector to inform every stage of what we do. So in terms of multi-jurisdictional, I should say this study is taking place in both Manitoba and Nova Scotia. It's collaborative in terms of the role of the knowledge users, and there are 5 phases now involved in the data collection, including a provincial survey, which I never envisioned as part of this project, but seemed like the best way for us to enter into conversations and start recruiting people in kind of the COVID context, was to create this short survey element that would allow us to reach out to our different groups and get a sense of the violence that they had experienced, and then whether or not they were willing to participate in interviews remotely. So today I'm going to focus on 2 pieces of this analysis, which have worked over the past 2 years, and that is the document analysis and then remote interviews, particularly with staff. So at this time, as I'm sure you can imagine, it's harder for us to recruit older adults who are receiving care in a remote context. So the group that we've had the greatest response from to date is our healthcare workers. So that's a bit about our study design. So I'll be presenting the sort of thematic analysis of the 25 documents that we found in Manitoba. So some of these are policy documents. I'll get to this in a moment. There's kind of a broad range of documents because of the nature of long-term care. And then we looked at 26 from Nova Scotia. We found these documents by working with our knowledge user groups, asking, our union representatives and long-term care organizations, like, what are kind of the guiding documents for you? What would be important for us to look at? And then we used a combination of inductive thematic analysis and then a critical discourse analysis, where, guided by Baki's "What's the problem represented to be?" we look at how the problem is represented within policy documents, what assumptions and concepts underlie this representation, and what are the effects produced by this representation. And in the final part of this presentation, I'll also look at trying to link what is said in the policy and other documents to how healthcare workers actually talk about their work. And so I will note that at this point, we're still engaging in interviews, so our analysis is fairly preliminary when it comes to our healthcare workers. But I think it's really important and timely to share this right now, especially because I think some of our healthcare workers in long-term care haven't had much of a voice during the past few years, as they've worked really hard to respond to the context that we're living in. So in terms of the documents that we looked at, there isn't an overarching long-term care policy in either Manitoba or Nova Scotia or federally. And so what we end up looking at is a combination of legal documents that relate to older adults and also to persons living with disabilities. So we have, like, the Protections for Persons in Care Act in both Manitoba and Nova Scotia, as an example. We also look at workplace safety and health acts that govern healthcare workers. We look more specifically at provincial policies that focus on violence prevention. Again, these are not specific to long-term care, but they focus on healthcare workers. And I think what you'll find, I hope you'll find interesting, is that they certainly reveal a lot about how the language around responsive behaviors, for example, has crept into healthcare settings more broadly. So it's not just specific to long-term care. And then we have some regional policy documents that we've looked at, and risk assessment type documents, and ombudsman reports and auditor general reports, as well as some statistical documents that we received kind of internally that report incidents of violence, and nurses union reports. So just before we move into this document analysis, and again, kind of building on this concept that we don't really have a long-term care policy. We are starting, many of you may know, we have a draft of long-term care standards, federal long-term care standards that came out late in January. This is the first time we'll have a federal long-term care standards document. But for the most part, Canada's long-term care system is really situated on the peripheries of health services and health policy, because it's defined as extended health services, right? And so as an extended health service, it's not insured, it's not part of the kind of commissions on healthcare and that sort of thing. So it's left out of a lot of these kind of governing pieces. At the same time, research over the last decade has really drawn attention to how these kind of structural level issues are having a profound influence on violence. So things like staffing levels, the task-oriented nature of care, the organizational culture. And relatively few studies have actually analyzed policies themselves. And I suspect that this is in part because it's such a patchwork of different documents that you have to look at to try to to really understand the policy context for long-term care. So I'm going to begin by sharing some of our findings from the document analysis. So we identified 4 dominant constructions of policy targets in long-term residential care policies or texts governing long-term residential care. And with few exceptions, the policies really exclusively addressed violence toward older adults or care workers. So again, this kind of division. We did not identify any policies that addressed violence toward family members or people residing in long-term residential care. We found that document materials often framed older adults as either vulnerable of abuse or as challenging and at risk of harming others. Both constructions emphasize individual level risk factors for violence and overlook the rights of residents to access information and to advocate for themselves. And we also found that documents addressing healthcare workers constructed them as either clinical risk managers or workers with rights. And these kind of 2 constructions were somewhat in tension with one another. So we begin by looking at the documents related to kind of mandatory reporting of abuse. When we try to look at what are the documents available or geared toward older adults themselves, they use the term abuse rather than violence, which reflects the vulnerable status ascribed to care recipients and the subsequent need for state protection and intervention. So think about the term abuse. It's often used to describe violence toward people who lack autonomy and full citizenship, right? So we talk about child abuse or abuse toward people living with disabilities. So all in these policies, all adults in care are represented as a singular group, and this implicitly assumes their vulnerability and need for protection. These documents don't reference the rights of care recipients, but they establish the rights and responsibilities of the state and institutions and providers to intervene on behalf of those in care. So the emphasis is on reporting protocols for staff and institutions and overlooks the agency of individual care recipients and families who may wish to report an instance of abuse or seek information about their rights, or maybe even advocate for themselves. So as an example for this, we see the Protection for Persons in Care legislation policy here from Manitoba. And part of the problem, of course, with this representation is this intrinsic vulnerability of individuals requiring care, but also the concept represents these fundamentally different things under the guise of a single phenomenon, right? So we see things like financial abuse, sexual abuse, physical violence. All of these things are responded to under the same kind of framework, which raises questions about really how effective can this be? Sorry, I just realized I wasn't advancing properly. So I missed you guys. Here is the Manitoba Protection for Persons in Care Act definition of abuse. I'll just let you guys read that. Okay. So the second category of policies related to older adults is policies and policy language that looks at quote unquote challenging behavior or uses the term responsive behavior. So in Nova Scotia, there's actually a challenging behavior program, a provincial program that addresses responsive behaviors within long-term care and home care settings. So responsive behaviors also emerged in violence prevention policies for healthcare workers in long-term care policy manuals and reports in long-term care to refer to any acts of aggression or violence or challenging behaviors or even non-compliant behaviors carried out by individuals with impaired cognition. In Manitoba, this term was routinely used in violence prevention documents and often inserted into definitions of violence to categorize violent behaviors that were carried out by individuals living with dementia. So this kind of implied problem is that despite some differences, policy documents in both provinces conceptualize responsive behaviors as a problem of individual pathology, requiring surveillance and behavior management. And this conceptualization of violence really obscures, again, the rights and responsibilities of people exhibiting responsive behaviors. It's kind of ironic that this term has developed as a way to acknowledge the expression and need and context of people living with dementia, but it, in a policy context, has become a little bit more of a labeling practice. And we'll get to that again when we look at the interviews as well. When we look at violence toward healthcare workers, both provinces have violence prevention policies for healthcare services, which stem from occupational health and safety legislation and emphasize risk management and clinical practice and training. So these policies weren't devised for long-term care contexts and don't address resident-to-resident violence, which represents the most prevalent form of violence in residential care. In addition, these policies are largely geared toward regulated health professionals and don't fully represent the composition of the long-term care workforce. So our healthcare aides, for example. So our occupational health and safety legislation in Manitoba and Nova Scotia requires employers to develop and implement written violence prevention policies, to conduct risk assessments, to determine the risk of violence within the workplace, to provide training, to ensure workers are aware of policies and procedures, and to investigate and document reports of violence. Although this legislation establishes responsibilities for employers and institutions at the policy level, the responsibility for preventing violence is actually shifted to employees, who are attributed the responsibility for everyday practice of risk detection and mitigation. So the problem is represented from a medicalized view of violence, pathologizing violence as something that's associated with a particular medical condition, generally dementia, and then the staff are responsible for managing it through risk assessment practices. This is in contrast to respectful workplace policies. So policies in both provinces drew on provincial human rights acts and emphasized the rights and responsibilities of employees. These rights included freedom from harassment and discrimination on protected characteristics such as age, gender, race, and sexual orientation. As such, there's a tension between violence prevention policies, which construct staff as responsible for the prevention and mitigation of violence, and respectful workplace policies, which construct staff as citizens with rights and agency. We see an example of this from our Regional Health Authority respectful workplace policy. So this is a very different problem representation in contrast to policies addressing resident abuse, which provide a single process for reporting cases of abuse that meet a threshold of harm. These policies also offer multiple avenues to address mistreatment, including addressing the issue of on your own, or consulting a supervisor or union representative, or informal resolution or formal complaint. So recognizing more the agency of workers. I should also note that these respectful workplace policies seem to relate specifically to actions by other employees, and it's not clear how the respectful workplace policies would relate to patients or residents or older adults. So there seems to be a bit of a gap in that respect as well. So when we turn to what healthcare workers actually told us within our interviews, our preliminary analysis has really focused on how this relates to policy discourses. So at times, we see that healthcare workers internalize or at least talk like clinical risk managers, that the way that they're kind of represented within policies. That is that they emphasize the importance of their assessment skills. It's really important to be able to identify, if someone is in pain. If they're in pain, it makes sense for them to be agitated, and perhaps they might even become physically aggressive because they're in pain, as an example. Or they might also emphasize dementia specifically. It's not really violence, or I don't think of it as violence because I've always worked in this kind of setting, and I know that working with quote unquote these people often involves a potential of a volatile or violent situation. At times, however, they also identify people who are just angry or who lost their patients, not because of the disease. And so we see this kind of contradiction at times between kind of recognizing some human needs and maybe even in some cases, if this person doesn't have dementia, it's even worse that they've, of course, struck out in a particular way or yelled or something of that nature. One participant even explained this contradiction, saying she would just chalk it up to illness because it's easier for her to continue to work without blaming the residents that she works with. And so here she explains that this kind of responsive behavior discourse can be helpful in coping with the kind of constant potential for violence within the workplace. Although workers explained that violence was in a sense normal, they also resisted the normalization of violence. And I think this really gets at the tension between being a worker with rights, as well as a worker with responsibilities to care for residents. And one of the things that was most frustrating for workers was when management or the kind of procedural processes normalized violence. So it's one thing for me to normalize violence as a way to maybe cope in that moment, at least using that kind of responsive behaviors frame. But it's another thing for management to say, okay, fill out this piece of paperwork and we're not going to do anything with it. So there was this sense that in normalizing violence at a structural level, then we're not really supporting workers, right? And we're also demanding that workers are themselves as individuals responsible for the violence, right? So we see this kind of responsibilization from a number of healthcare workers in our interviews. So they talk about trying to, think after a violent incident about how they could have done things differently. Think about what's happening. Did I try not to take it personally? But at the same time, they recognize that there's an impact that this kind of responsibilization has on them. It doesn't feel good. As the final participant on this slide says, it's not pleasant, but you're sort of told that this is part and parcel of your job. And then you have to think like strategies, to prevent this, right? So I want to recognize that at this stage, we're still looking at some preliminary data. The documents cover multiple healthcare settings, and we weren't able to access documents that weren't publicly available. So for example, although we're trying to look at both long-term care and healthcare settings, or long-term care and home care settings, we can't find any publicly available home care policies that relate to violence. We also have no organization-specific policies. So what we'd like to do in the future, when we actually have an opportunity to go into do some observational work in a couple of long-term care facilities, is look at what the particular organizational policies are in relation to violence. In terms of our interviews, what I've presented to you today generally represents our more educated healthcare staff and I would argue, our less vulnerable healthcare staff. So we have to date interviewed 3 healthcare aides, and we're still actively recruiting healthcare aides because they provide the great majority of direct care, and as a consequence, experience a greater proportion of violence. And of course, crucially, we want to actually understand what older adults themselves think about this. And part of that is also being able to get into facilities at some point, and looking at how older adults interact in kind of congregate settings. So I hope that that's something that we can address in the next few years. But those are some of our limitations. So we're continuing to recruit and analyze our interviews with our care workers and family carers and older adults. We're going to work on analyzing survey data, hopefully doing some in-person observation, and comparing this all with what we find in Nova Scotia. So it's hard for me at this stage to sum this up in a nice bow. It's not a project that lends itself well to that. But I think if I could point to anything, it's kind of these tensions that exist. On the one hand, we have care recipients constructed as vulnerable to abuse, and on the other hand, they're constructed as challenging and requiring behavior management. We also have this tension in the way that we construct our healthcare workers as responsible for violence, but also workers with rights. And it's not always clear that those rights are recognized within the context of these situations in care. And part of the problem is that the focus remains at the individual level, and it tends to really overlook these larger institutional and structural factors. I'd like to think that things like our current kind of focus on long-term care federally would help us kind of move forward some of these issues and think about how we might address them. I also question how this clinical risk management discourse is working. It seems to me that when we pathologize and normalize violence, we actually fail to understand and kind of follow through with the responsive behaviors concept that is actually supposed to help us understand the meaning of this all. Instead, we sort of attach a label to the person and we stop paying attention to what's happening around them. And that also responsibilization places a lot of pressure on our care workers to manage not only the residents, but also to do a lot of emotional labor at the same time. So those are my comments rather than conclusions, and I welcome questions and discussion.
Fantastic. Thank you so much, Rachel, for sharing with us. I think you're really timely, important and needed work. At this time, I will invite those who might have a question to either perhaps raise their hand or unmute themselves. I see we already have a question in the chat from Anthea, and I'll just read that out if that's okay, Rachel. And so Anthea says, thanks so much for your talk on a really important issue. And just a few questions. Perhaps you might have said this, but it always helps, I think, to reiterate and clarify. Is the current study dementia focused, or perhaps I'm wondering if maybe your PhD work was focused on individual. I think you mentioned, sorry, that your doctoral work was focused on individuals who are living with dementia and their former care providers. Maybe we'll start with that.
So I think it's a good question, right? Yeah. It's a confusing part of I think this study, in the sense that this is not exclusively focused on dementia. It's focused on long-term care settings, but because of the fact that long-term care settings and the whole kind of discourse around violence in long-term care settings is shaped by dementia care, right? It's shaped by this concept of responsive behaviors, albeit I don't think it's really doing justice to this concept, which was meant to, destigmatize the violence in dementia. So it's not exclusively focused on people living with dementia, but it's certainly something we can't get away from in long-term care.
And there's a few other parts to Anthea's chat question here. And Rachel, please correct me if I misheard. From what I'm understanding, the study that you've been able to do thus far, because there have been, I think, restrictions that COVID has inevitably placed, but you've been looking thus far in speaking with long-term care staff who are working in long-term care facilities. Is that right? And if, I think Anthea also is wondering if you're planning to perhaps expand your study to look at individuals who are perhaps receiving care in their own homes?
Yeah, yes, that is correct. So we will be talking to older adults who are receiving care in their own home, and to older adults receiving care in long-term residential care facilities. It's quite a month.
Can I speak? It might be easier in terms of
I
asked multiple questions there. I completely accept what you're saying about dementia care is obviously part and parcel of long stay care, but I'm curious, when you've collected the views of workers in terms of their experiences, did you actually did you get any information as to whether they experience more violence by people living with dementia, or did that just not come up? And then I was kind of curious about the violence that older people themselves experience from care workers, because I've done work in care homes and hospitals myself, and the violence that older people, my field's more dementia, so I'm talking specifically about dementia, the amount of violence that they experience in quite routine ways, and often staff are very open about it. So I'm just wondering, even when you've spoken to staff and you've talked about the violence they have experienced, did they talk about violence that they perpetuated to the older person, or did they focus more on what they experienced?
Which is it's a really good question, because I was thinking actually about some of the summaries I was reading, interview summaries I was reading through this morning, and sometimes staff will say, like, they'll talk about, the use of force to manage a resident. I'd have to look back and confirm that it's a resident with dementia, but they are a resident who's perceived as a violent or aggressive resident. And so in that case, there is this sort of acknowledgement of force. They don't use the term violence when they're talking about that use of force, but they do say things like, it would be, if people on the outside could see this, right, they would think it's really strange, right? So there is this acknowledgement that this is not sort of socially sanctioned behavior, right? So that's the latter part of your question. Sorry, I think you asked a couple of things. So if there's something I haven't addressed, please let me know.
I guess I'm just curious to know how you are going to find out, or if you will find out, about the violence that older people themselves experience from the workers and family members.
So
at the
that's
moment it seems kind of focused on what the workers experience rather than what
right. And so that's partially a limitation of the remote nature of work right now, and not being able to get into long-term care facilities over the last 2 years, as well as not really being able to meet in some of our kind of community organizations that would serve older adults. Like, we haven't had the opportunity to be in person. So it's been a lot harder for us to actually recruit older adults. So we were hoping that there would be kind of two ways for us to get at their experiences, and that one would be through recruiting people who can participate in interviews, and the other would be through the observational study as well, where we can actually watch and not just look at, or not just listen to what people say about their experiences.
Just kind of watch this space for the bigger picture.
Yeah.
Look forward to hearing that.
On, I suppose, that note of participation, there is a question in the chat about if you are recruiting, or if someone can participate in the study. I imagine, given the study that you've been discussing today, it would be relegated to individuals who are in Manitoba or Nova Scotia. Is that right?
Yes. Yes.
And perhaps if this individual fits that criteria, perhaps they could send you an email if that.
Absolutely, which I should have put somewhere on my presentation.
If you want to type it in the chat box, that would be, I think, fantastic.
I always try to end with the concluding comments so people can actually tell me what they really think about what I said.
Great, thanks, Rachel. And if I may, I'm not seeing any other questions. I had a question actually, in thinking about, I suppose, risk management and reporting mechanisms in terms of kind of reporting or capturing violent events or acts. In either the interviews you had with care workers or in the documents that you analyzed, I wondered if you noticed the role of technology kind of configuring in as technology is increasingly integrated into long-term care, often for surveillance. I'm wondering if that's becoming, I suppose, an important actor of sorts in violence that's happening in long-term care.
Yeah, so technology, I guess, when I think about both the document analysis and the interviews, I would say technology comes out when we're talking about surveillance and the use of surveillance, video cameras and that sort of thing, in terms of watching people. The other thing that I'm thinking about in terms of technologies too is the kind of nature of incident reporting as kind of a technology itself, right?
Mm-hmm.
But I'd have to think more about that.
I wondered then, because you were talking about the responsibilization of care staff, I wonder if technology, unfortunately, while a helpful tool, at the same time, it becomes another source of care work that staff have to monitor and then act on, depending on what's being captured or surveilled as well. So it's kind of both a blessing and a curse, which is, I suppose, what technology often is.
Absolutely.
So a question here from Fran Scott. Are there any, I suppose, takeaways from violence prevention in school settings that perhaps could be applied to long-term care settings?
I don't know much about violence prevention in school settings.
Rachel, I just was thinking that there are some comparabilities, children being considered vulnerable, but also having challenging behavior, teachers feeling responsible. The institutional setting and the surveillance around it is somewhat similar. I think there are some differences, particularly in terms of reporting. Child abuse is reportable, whereas elder abuse is maybe not so much. I just wondered if there might be some ways of conceptualizing it in a similar way, to help understand violence with seniors.
Yeah, I think there's a lot there. Yeah, there's similarities, but maybe a lot of distinct issues in relation to disease, and that kind of dementia piece has such a profound influence on the way, the kind of stigma associated with dementia and a lot of the labeling practices, even within, in Manitoba and Nova Scotia, both provinces have labels, purple rings or wristbands that they associate with quote unquote violent patients. And the Alzheimer's societies have, come out against these kinds of practices. But yeah, I feel like it's a very different response in that respect, in that, we wouldn't go into a school system and give a kid a purple wristband and say, this is the violent kid.
Good point.
And I wonder too if our construction of dependency and dependent is so different in these two groups as well. But I hadn't considered that question before. Gavin, did you have your hand up, or am I just mistaking? Oh, I see the hand was up and the hand for typing.
If that's okay.
Did you want to walk us through your quote, or would you like me to?
Yeah, that's great. I was just thinking about, like, you put like care into a search engine these days, and not only does all the caring literature come up, the traditional stuff we know as gerontologists, but there's this whole wider sort of notion of care in disciplines like geography and sociology now. Whereas care is extended beyond caring relationships and institutions to denote the care society has for different people and situations, and that can sort of surface in different ways, in meaning and agency, but also in sort of more general atmospheres that exist in everyday spaces. So I wondered if there's like something that might be written about the relationship between this broadened societal notion of care and violence in care settings, because whether we care, society cares, and what that care surfaces as is an important opposite side of the coin, if you like.
Mm-hmm.
But I suppose it's the relationship. So I'm just really sort of trying to focus on the relationship between what you're talking about and this much sort of more broader notion of care that's coming out in literature.
Right, and I think there's kind of an opportunity for us to do more thinking about this broader notion of care, and also kind of push governments and institutions to think with us, or apply our thinking, this idea of a caring society, and what does that actually mean? I think, to me, it seems obvious that it shouldn't be so strongly associated with violence.
Yeah, it almost seems that it takes something like violence or a situation like COVID for society to care, for that care to emerge as a social force.
Yeah.
Thanks. Something to think about, something maybe to work on.
Yeah.
or as Gavin was speaking, I was thinking about too how, even the ethics of care, it is evolving and changing, and they've just added another ethic of care to consider, and how that, I don't know how that might align or be thought about in an interesting way in some of your work. So we're beginning to approach, I suppose, the end of our session here, but I'm wondering if anyone has a last query for Rachel. And again, she's helpfully included her email address in the chat box, and I'm assuming, not to put you on the spot, Rachel, that you're happy to entertain questions if folks have something that comes up later on.
Absolutely.
Okay, seeing and hearing no other questions, I would invite the audience in joining me in thanking Dr. Heron for joining us and for providing such a fantastic seminar to wrap up our series for this year. Thank you so much, Rachel.
Thank you.